Now it's my pleasure to introduce Rafał Dziadziuszko from Poland, and he will be focused on stage 3, the best treatment option during and after radiotherapy. Thanks, Rafał.
Hi, everyone. Thank you very much for your kind invite to this excellent meeting. I'll try not to bore everyone with radiation talk in the morning. For me, looking at unresectable stage 3 non-small cell lung cancer means optimizing local control with radiation tools that we have and optimizing systemic control with systemic therapy tools that we have. As simple as that. And I would like to come down with this notion during my presentation. How do we then optimize local control? Well, first of all, we have learned over the years that concurrent treatment is better than sequential chemoradiotherapy. You know this analysis of overall survival from 2010 that tells you that there is a clear advantage of concurrent versus sequential. But importantly, to keep in mind what concurrent chemotherapy actually does during treatment, it increases local regional control. As you can see here on this slide, that the probability of failure, local failure, is just lower with concurrent chemoradiation as compared to sequential, but we are not addressing systemic disease. And that's important to keep in mind. Systemic control with concurrent versus sequential is exactly the same. So what are the results of concurrent chemoradiotherapy in pre-immunotherapy era? You can see that long-term survival of stage 3 non-resectable patients is roughly 30 to 35%. That comes from the PROCLAIM study, which evaluated 2 different backbones of chemotherapy, the START trial with immune vaccine, and some other studies that are presented here. So this is the situation before immunotherapy and before PACIFIC. Our local failure rate in the primary site was slightly higher consistently across the studies than the regional failure rate, which is 10%, despite that we are now irradiating only involved lymph nodes. But most of the problem comes from the distant failures. With that, I would also mention that the quality assurance of your radiotherapy program is extremely important. The PROCLAIM study was a very nice industry-sponsored study that looked carefully at the radiation side of the protocol. And in this subset analysis from the study, you see that the patients who had no deviations from radiotherapy control, quality control metrics did best, whereas those patients who did have some deviations from plain radiotherapy that was centrally tested did worse, with big difference in overall survival. So that's important. But also over the years, we have little tricks of radiation, such as, for example, esophageal sparring. That means constructing the gradient through which you can spare the contralateral side of esophagus, trying to minimize esophageal toxicity. And that remains important because our volumes with radiotherapy are much higher than we used to see before. So, to sum up this part of my talk, optimizing local control comes from quality radiotherapy. That means breath motion control, onboard imaging during each fraction, etc. The questions for radiation oncologists, whether we can adapt to the target volume, meaning replan the treatment during each fraction of radiotherapy, which is now possible to optimally cover the target volume without damaging organs and risk. And then the question is whether we should shoot higher dose to the primary tumor, for example, with SBRT boost to the primary to minimize this 20% local failure rates, with keeping low dose to the organs at risk, which we know is very important, particularly the heart, lungs, and esophagus. And the hard dose becomes quite important based on RTOG0617 study, because especially for patients with hard medical history, there will be potential problems with high radiation dose. Now let's shift the gears and let's talk about optimal systemic control for our stage 3 unresectable patients. First, with immunotherapy. I will not show the design of the PACIFIC study, which you know very well, but just see that this is something we have been waiting for years. Better systemic control here through consolidation with 1 year of immunotherapy. And you see the advantage in overall survival keeps with time, and it's about 12%, the same advantage as you can see from some adjuvant or neoadjuvant studies with immunotherapy. So what are the new studies that we should keep in mind? I'll start with PACIFIC-5. That was the results that were shown just 3 months ago, with durvalumab consolidation until progressive disease versus placebo in subset of patients treated with concurrent but also sequential chemoradiation. Sequential chemoradiation still takes place because of the volume issue and because of the problems in terms of possible toxicity from concurrent treatment. We know that the study is positive. We don't see the full paper yet. The progression-free survival hazard ratio was 0.75 in both concurrent and sequential subset of patients. The number of patients was small though, and we have to see the full paper to really see the PACIFIC-5 study results in full. Now, PACIFIC-2 study actually asked the question whether concurrent immunoradiotherapy is better than concurrent chemoradiotherapy. Here, the patients who were treated with concurrent durvalumab and chemoradiation were offered consolidation durvalumab, whereas patients on the standard of care were not treated with immunotherapy at all. And we know that the PACIFIC-2 study is negative. That was shown last year during ELCC. And it's important to keep in mind also another big study with almost 800 patients, Checkmate 73L, explored the classical Durva with concurrent chemoradiotherapy as compared to Nivo with concurrent chemoradiotherapy and Nivo-IPI. Here, Nivo and Nivo-IPI were also given concurrently with chemoradiotherapy. We don't yet see the full paper from the study, but we also know that the Checkmate 73L is a negative study. And other studies are waiting for the readout. Here is the study that I'm participating in the steering committee with consolidation Durva versus consolidation Atezo and tiragolumab. But here, this is purely consolidation after concurrent chemoradiation. We are waiting for the readout of the study. The other trials, important PACIFIC-9, is a study that builds up on the phase 2 study with consolidation treatment with Durva monotherapy or PACIFIC and Durva and other checkpoint inhibitors added to this consolidation phase. A very important study that is now accruing patients. And durvalumab after radiotherapy alone, this is a relatively small subset of patients with comorbidities, the elderly, poor kidney function, and so on, that we cannot offer chemotherapy at all, and we still like to treat these patients with high-dose radiotherapy, either in the palliative range or in the radical range, that means 60 grays plus. And in the single-arm study, immunotherapy added as consolidation for 12 months or more than that seems to be better than historical control, but you cannot draw definitive conclusion because of the lack of the control group. And also, very important, we need to put these data into perspective of optimal systemic control with targeted drugs. And here comes the LAURA study, which exclusively focuses on EGFR mutant patients post-concurrent or sequential chemoradiation with osimertinib given forever versus placebo, with huge difference in disease-free survival, telling you that the optimal systemic control here is simply targeted therapy, which works well in EGFR mutant positive patients. Given the nature of the disease, you can also expect systemic failures in high proportion early on after concurrent chemoradiation. Another example, how to combine systemic treatment with concurrent chemoradiation. So now, having this data in mind, let's review the basic principles of radiotherapy drug interactions, taking into account the results of the current studies. This is a nice table that comes from the old review written in Green Journal that I modified a little bit with immunotherapy reason as an example of the reasons to combine drugs with radiotherapy. For the residents in the room, I would just mention the spatial cooperation addresses local control with radiation, a systemic control for distant mets, with an example of adjuvant or neoadjuvant chemotherapy and radiotherapy in breast cancer. Cytotoxic enhancement built on radiosensitization with cisplatin in non-small cell lung cancer, where it affects local control primarily and not distant controlled. Biological cooperation, we unfortunately didn't have a positive study with tirapazamine for a number of reasons. Tirapazamine is hypoxic toxin that works better for these tumors where we have hypoxia. And then temporal modulation with cetuximab and radiotherapy. This example comes from the head and neck field. We don't have drugs to reduce toxicity. Amifostine is an old story that tried to address this or other agents, but we don't see that really from the current clinical use. And then, importantly, these days, enhancing immune response seems to be important, with hopes to improve antigen presentation with radiotherapy, and we have a lot of preclinical data on that. Possibly, this is how concurrent chemoradiotherapy plus consolidation immunotherapy works. So these three principles in red are important from the topic of concurrent chemoradiation and immunotherapy. The spatial cooperation is definitely addressed with immunotherapy in the consolidation manner as shown in Pacific and Pacific 5, and LAURA with targeted drug, osimertinib in this case. Cisplatin is a great example how we benefit from improved local control in non-small cell lung cancer with concurrent chemoradiation. And then enhancing immune response, again, seems to be the case for immunotherapy with radiotherapy, but probably not given concurrently. So take-home messages from this part of my talk: immunotherapy, given as a consolidation treatment, is associated really with unprecedented survival improvement in stage 3. And that's Pacific and Pacific 5 readouts, and probably the ways to combine new agents, BiTEs and other immunotherapy agents in the consolidation phase, in my mind, is important. The data for concurrent chemoradiotherapy and concurrent immune checkpoint inhibitors are disappointing. The question then is, are we really shooting with radiation and our own rescue mission team, which is lymphocytes in this case? This is clearly the case in Pacific 2 and Checkmate 73L. And the burning questions for the future are as follows. As radiation oncologists, how to optimally develop our local control questions? Should we address the optimal volume, dose and fractionation, the typical questions that we have with modern radiotherapy equipment, and then duration of radiotherapy, which we try to keep shorter? Next question, the optimal patient selection for radiosystemic therapy should be based on both clinical, because this is a special population of patients, and molecular features of the tumor to optimize systemic control. The combination strategies with new ICIs and targeted agents in stage 3 non-resectable will be extremely interesting topic in the field. And my bet is that the most interesting question for the future, and also given Patrick's talk on KRAS and immunotherapy, is how we're going to address KRAS mutant patients with novel KRAS inhibitors, and the fact that some of these patients do benefit from immunotherapies, unlike EGFR mutant patients, in the very near future. With that, I would like to thank you for your attention. Gracias por su atención.